All right, so we are now recording. So let's get into our case study. All right, and this is going to be open up for anybody to discuss. Questions will be coming along here, and so feel free to take part. All right. So as we're maybe hold on. All right, now here we go. All right, so you're dispatched at 1412 to a rural two-lane highway. You had a single vehicle MVC car into a ditch, moderate speed, one patient conscious and alert. And 911 tells you by way of a caller, patient's talking but appears shaken, seatbelt is worn, some bleeding from the right forearm. So, what are you thinking about on your way to the scene? What are the things that you need to be thinking about? And again, this is kind of getting you ready for your registry exam for that 3-section type of question. Chris.
The most important piece of information we can get before getting there: how old are they?
Okay. So, why would age be important to know? Julia. Okay, very good. So age would be important. What else would be important? All right, very good. So you begin to think about your dosage, Julia.
Um, Knowing whether they're still inside the vehicle or they're outside.
Okay, good. Very, very good.
Having a fire truck do like extrication and stuff like that, but also let you know a little more like, are they like breathing like wounded or are they like critical?
So you guys are starting to think like clinicians now. That's perfect. Dylan, and then Ashton. Okay. Now remember, you're on your way. You're not there. Not quite there.
Think about on the way there is you need to check for as well.
Perfect. Perfect. Ashton.
Start to think about any additional factors involved in the crash. To
Such
figure out
as?
whether it's like, was there something in the way? Because you want to figure out. Well, you'll know when you get there, like the mechanism, whether it was like a medical cause or traumatical.
Very good. Traumatical. I like that.
I didn't come up with that.
Is fire and law enforcement area?
Okay. So again, all these things are important because what it does is it gets you into, stay with me guys. It gets you into this thinking of, okay, how old is my patient? Older patient, younger patient. Thinking about DCAP BTLS. So you're beginning to think about your patient assessment. Other factors, it's kind of like, well, why did this person wreck? If it's a rural two-lane highway, did somebody cross and force them off the road? Did an animal run out in front of them or whatever? So, again, these are the things that you're going to want to be thinking about. You get on the scene, and here's your initial survey. Patient's airway is open and clear. He's breathing spontaneously and unlabored. Got radial pulses that are present. There's no major bleeds aside from the right forearm laceration, and it's not bleeding too terribly profusely. His GCS is 15. It's about 65 degrees out and no other visible trauma. So what are you thinking about just based off of this? Because again, you don't have a ton of information off this initial assessment. But what are your thoughts about this particular assessment? Jack.
I want to know what caused the crash.
Very good. And what else can you gather by trying to determine what caused the crash?
What their chief complaint is.
Definitely chief complaint, but something even before that. Chris?
Mechanism of injury.
Okay. Before that. These are all important, but even before that, when you're talking to the patient.
I was gonna say that's not the right answer, but the damage of the vehicle, like you into the mechanism.
Okay.
Mental status. Of my
Mental
patient.
status. Okay. Very good, Ashton. So mental status is going to be really important to determine. Okay. So as we get there, we're talking to the patient, we're finding out, and all the things that you guys have mentioned are important, but the number one most important thing starting off is the patient's mental status. And remember, the patient could be anxious because he or she just had a wreck, or they could be anxious because they are in compensated shock. We don't know yet, okay? Get your vital signs. Heart rate's 130, BP's 112 over 74, respiratory rate's 22. Cardiac monitor is shown. This is a 6-second strip. What do you see?
Sun.
Okay. In title is 32. Skin's pale, cool, slightly moist. He's anxious but oriented. Now, what are you thinking? Okay, so are we sure that this patient is in compensated shock?
No.
Does it matter? No. We're going to assume the worst until proven otherwise. And again, let me stop here for just a second. As a medic, as a healthcare provider, regardless, and you guys are, some of y'all are going to go on to be physicians. You want to look at your patient and assume what is the worst thing that can happen next to my patient. Now, here's the thing I want to give you a little bit of mental health help. That's a great thing, Holly, for a paramedic. It's terrible for real life, normal life. Okay, so be really cognizant of that. Of you can get into your, you can get into looking at, well, what's the worst thing that can happen in all aspects of my life? So just kind of keep that in mind. But I digress. So what are going to be the things that we're going to want to assess on this person? What else, Julia?
I mean, I remember looking at like the one on the arm to see like how much it's bleeding, how bad it is, and then start assessing probably my main concern of like abdominal trauma.
Okay, very good, very good. Chris?
I don't know if we got an age on the patient, but I like the medical history in case they're on blood thinners, because that could open up a whole realm of other injuries, especially ones.
Absolutely, absolutely. Understand that many people over the age of 40 are taking aspirin. Okay, that's just part of getting into middle age and moving forward. And so again, much like Julia said, if we've got internal bleeding that's going on, even if we're not seeing a lot coming from the forearm, this could be potentially bad. Ashton.
Treating my patient and not my monitor.
Okay.
Like, because you could also check, because yeah, I mean the monitor is going to give you your heart rate, but you're going to want to know, like, is it matching their pulse, and then like how good is that pulse? Like, is it 30? Is it weak? Or is it like a strong bounding pulse?
Outstanding.
Check cap refill too to make sure that they're still perfusing well.
Okay. These are all things to begin thinking. Okay. Here's your secondary assessment. Right forearm laceration, bleeding is controlled. Juliet, look right here. Abdominal area is distended, tender in all quadrants. Good pickup. No chest wall instability or deformities. No long bone fractures. What are your thoughts now? Potentially internal hemorrhage. Okay. All right. What are you going to do for this guy?
Yes.
I would say, yes, you are correct. However, I would tell you, you need to do something prior to that. It is time sensitive. What do you have to do before TXA?
To start a line.
You want to get a line started. You want to get your line started as soon as you possibly can. All right. So you said what?
Patients.
Okay. What flavor?
Let's go with in case it's because then we're thinking some sort of stomach GI thing. Definitely you want to line that's
Get out of here. You said so. Get out of here. Just leave. Just leave. Do we give normal saline for shock?
Yes, if you're to administer blood.
That's if you're going to get administered blood. But do we give normal saline for shock? No, we give LR. We give LR for fluid replacement because remember, normal saline is acidotic. Acidosis is the enemy of your patient. Okay? Now, again, what Chris is saying is exactly right. You want two IVs. One is going to be normal saline because if we're going to get blood at the scene, we're going to have that. If they're going to get blood at the hospital, they're going to have that. The other one, though, that we're going to give for fluid replacement, if we're not giving blood, needs to be LR because it's buffered. It will not make our patient nearly as acidotic. What else are we going to do for this guy?
Serial blood pressure evaluation.
Okay. What else? What else? Let's think treatment right now. Why TXA? What's TXA do for this patient?
Helps strengthen the clots.
What's your dose of TXA?
2 grams.
Okay. What is one key thing to remember about timing of TXA?
Feel like
3-hour onset.
Of what?
Within 3-hour onsets of the
GRP.
GRP of the symptom.
Right. So it's not 3-hour onset of your arrival, it's 3-hour onset of the trauma. Okay. What else? Does this patient need oxygen?
Yeah.
Okay. One thing every one of y'all have forgotten. No. Treatment. Nope.
Talking.
Moral support. Keep them warm.
I was going to start crying. Yeah. Keep your patient warm. It's very simple. It's very easy to forget, but it is critical as far as helping to keep your patient from spiraling downward. Okay. Very, very good. All right. So as we're going in this, based on what you know right now, do you need to board this patient? No. Okay. Spine boards are being relegated to a large degree just simply for a temporary transportation device to move a patient from point A to point B. But in this situation, there's really nothing that indicates that the patient is having any type of spinal injury. And even if he did, we probably wouldn't want to mobilize him on a board. Okay. So we've already talked about this. Again, remember the impact that we have as far as the choice of the crystalloid is that normal saline is acidotic. It's going to make our acidosis worse. When a trauma patient becomes acidotic, what doesn't happen? Clotting doesn't happen. So again, things to kind of remember here is number one, if we're making our patient more acidotic, the TXA that Shauna correctly identified is not going to be nearly as effective because now remember, TXA does not cause clots to form, Tacey. It strengthens them. But if we don't have clots that form, then there's nothing there to strengthen. The other thing that is just as important is keeping that patient nice and toasty warm, because if they're burning up and they're going through their ATP trying to manufacture heat, now they don't have that ATP to help to build those clots as far as you're going through. Okay. So you're in Rental Hospital. Heart rate now comes up to 124. BP's at 104/68. Respiratory rate's gone up to 22. You see EKG over there is shown. End-tidal is now 29. Skin is pale and diaphoretic. Under mental status, he has slightly delayed verbal responses, but he is still oriented. Okay. What's happening to your patient right now?
He's decompensating.
Now,
He's moving towards decompensating.
okay, very good. So the blood pressure is beginning to fall. Heart rate is beginning to go up. Respiratory rate is beginning to go up. And so our patient is beginning to decompensate. Now, keep in mind, what are some things, not only on this patient, but what are some parameters that will accelerate decompensated shock?
Advanced age.
Age or advanced age or
Very young.
very young or,
Very sick.
okay, a depressed immune system or anticoagulant use. Anticoagulant use. Okay, so if you got a patient that is taking Eliquis or taking aspirin, that can lead into that as well. So again, we talked about TXA here, and this is exactly right. So basically what we want to do with TXA is we want to give it over 10 minutes. And in this situation, basically what happens is it keeps the body from breaking down the clots. It makes them stronger. Now understand that the longer you are removed from the insult that caused the trauma, much like you said a while ago, the less effective it is and the side effects begin to increase. So again, giving that TXA as soon as you possibly can is going to be perfect, okay? Giving it within the first hour is awesome, but we can give it up to 3 hours, okay? So what about an end-tidal, okay? So the end-tidal was 32, and now we're down to 29. What does a decreasing end-tidal mean, Chris?
It could be indicative of potential acidosis.
Okay, And this is especially true in a patient that is not intubated. And this guy is not intubated. He's still responsive. He's still talking. He's slowing down his responses. Go ahead.
Now, is it also true that the end title is always a couple, like just a few values off of what the PaCO2 is, so it's kind of it's close to what that might be?
It's very, very close. The other thing to kind of keep in mind is that we want to couple this up with our pulse ox, okay? And so we look at end tidal, we look at pulse ox. And remember, pulse ox tells us what happened about 5 minutes ago. End tidal tells us what happened about 5 to 10 seconds ago. So we kind of get a very, very good picture in that. It also helps us to identify what's going on with metabolism of oxygen production and carbon dioxide production within the cells. Okay, so this is going to be really, really important. So again, remember, your end tidal, we look at this and we think of it as a measurement of a gas. But in reality, what we're looking at here is that it's an indicator of perfusion. How so? How does end tidal help us to know, Ashton, how well our patient is perfusing?
Well, it is getting lower because he is not, the oxygen and CO2 aren't exchanging. And so since those aren't exchanging, the volume is going to keep getting lower. So it's showing that he's retaining
Okay.
CO2. So
Yeah.
it's not perfusing well.
Yeah, really good. So again, his blood pressure is, let's say he's got a blood pressure of 112/70, and he's got a heart rate of 120. So it's up. But again, if his end tidal is dropping, that's telling us that from a 10,000 foot view, Jack, that looks pretty good. But now you guys have this tool that you can look at and you can say, we're not getting good perfusion at the cellular level. And that allows you to be aggressive for this patient as far as when you're going through. Does this person qualify for blood? 100%. 100%. Okay. So again, what are some of the dangers that we would see if we only resuscitated this patient with IV fluids? Jack? We're not giving any clotting factors, and not only worse, if we raise the blood pressure up and he continues to bleed, we're forcing those out of the body. Very good. What else? It's one that I've already harped on. Shauna. We're diluting the blood cells, which is we're making them anemic, okay? Which means the oxygen carrying capacity is going to drop. What else? Remember, we already talked about this one.
I was gonna say like 10%.
Okay, so when we give fluids, blood or IVs, what do we need to try to do? Warm them up. Okay, warm them up. All right. More and more I see where ambulances are now carrying IV warmers, and they're for the ones that are carrying blood, because remember, blood's got to be kept cold. We really don't want to, James, be giving cold fluid to our patients. Okay, so we don't want to accelerate that coldness that's coming into them. The other thing to remember is that, again, if we're giving them normal saline, depending on what your protocols are, if your protocols are calling for normal saline, you need to advocate for LR. But again, it can make our patient much more acidotic. Okay, so now explain to me. You guys become the teachers. Tell me about permissive hypotension. What is it? Why do we do it, Ashton?
It is giving enough fluids to be able to maintain usually like a pressure of like non-desystolic, just
Okay.
enough for organ perfusion.
So what is your range for permissive? Your systolic range? 90 to 100, okay? We want it up to 90 because 90 is typically what?
Where you, yeah.
This is what we need to perfuse the tissues, okay? Upper level is going to be 100 because if we go up above 100, what is the possibility of happening? You just did it. Yeah, we blow out the clots, okay? And again, if we raise that pressure up too much, again, coming back to what Shauna said earlier about giving TXA, if we raise the pressure too much, the TXA is not going to work. We're going to break those clots up, okay? When we're giving fluids, what else do we want to assess early and often? Lung sounds, okay? Especially on your older patients, okay? So when we're getting to the hospital and we're doing our handoff, what are the 3 things that you need to communicate to the hospital? Jack.
Their injuries, their signs and symptoms, and the treatments you provided.
Very good. Okay. And many times what that's going to be is that it can be a little bit longer than what you're going to have on the radio report. With a radio report, remember, it needs to be short, sweet, and to the point. Basically, I got a patient's coming in, massive trauma, more on arrival. Tell them a little bit about what you've done, and then when you get there, you can do a much greater report. If you're working and you're taking a patient to a trauma center, many times what they'll do is they'll call a timeout and everybody will be quiet. It'll be you talking to the physician, and nobody else talks until that information is shared. So again, let's talk a little bit about what's going on here. What are the physiological changes that bring about compensated to decompensated shock? Not just the vital signs, but what's happening at the cellular level. Chris.
At the cellular level, the body has kind of burnt out its reserves that it's saved up in preparation for stuff like this, and it's no longer able to sustain the compensation.
Okay. Very good. What else?
In compensated shock, your blood's shunting to vital organs. When you're decompensating, they're not being perfused well.
Perfect. Very, very good. All right. So again, not only are we looking at blood loss, but we're looking at blood shunting as well. That's why typically what you would see is that if a patient begins to become pale, you're going to look at the extremities. If you're looking for diaphoresis, you're going to be looking at the extremities. Okay. Let me ask you a question. If you've got a patient that has pale extremities, but they've got circumoral cyanosis, what's happening?
They're not getting enough oxygen up here.
Okay, so they're not getting enough oxygen up here, all right? And this is a terrible sign because remember, cyanosis is a late sign. Secondly, remember that what little blood is being left and being shunted into that area is not carrying enough oxygen. What do you need to do for these particular patients?
Warm them up.
Warm? What else? Oxygen, okay? In that same situation, these are, again, I want you to begin thinking, I'm going to give them blood. Okay, we're going to give them blood because what we're going to do with blood is we're going to increase the oxygen carrying capacity of additional red blood cells, and we're going to put some clotting factors in there as well. Again, we kind of touched on this a while ago. Why is the end tidal a more reliable indicator of shock than your blood pressure? Because it happens so early. Chris.
And it's a real time value, and it's like more accurate. I know, like when the monitor calculates blood pressure, it's calculating the map, but also it's more reliable and it's close to your arterial.
So very good, very good. So we want to monitor the blood pressure. We want to monitor the map, and what other measurements related to the blood pressure do we want to monitor?
Pulse pressure.
Pulse pressure. What is pulse pressure?
It's watching the difference between the systolic and diastolic.
Perfect.
Because
Go ahead.
actually, I want to hear what you have to say. I'm learning.
So as that pulse pressure gets smaller, that's an indicator of what? Okay. Shock.
Yes.
Okay. Internal bleeding in this particular patient, most definitely. But again, you can see it in like anaphylaxis. You can see it in cardiogenic. Yes.
Isn't that because the first number is going to be low because there's not enough perfusion to build that pressure?
Correct. So the heart itself is beginning to fail because remember that first number is what the pressure is when the heart contracts and ejects that blood out.
And then when it's high, isn't that that's more or less like a mechanical issue because that's why your diastolic is still good because you're still getting that adequate refilling, but it's having a problem pushing.
Correct. Yeah. So a widening pulse pressure typically indicates what?
Intracranial.
ICP. And in particular, what we want to do is we want to watch for widening pulse pressures with head trauma and strokes. Okay. The other thing we might want to look for as far as a widening pulse pressure is a patient that has some type of a brain tumor as well. Okay, so we want to watch that really, really closely for our patients. We've already talked about this. If we give too much normal saline, we're going to turn our patient into an acidotic patient. It's going to run into problems. We've talked about hypothermia. Okay, you picked up on that, so that's very good. So again, if we got a patient that's got a TBI, what are we going to do in regards to fluid replacement? Jack,
Administer hypertonic saline.
okay.
Yes.
If you don't carry hypertonic saline, now what are you going to do?
You're not just gonna adjustment.
Say it again.
I said you're not just gonna bolus LR because you're gonna miss blood pressure.
Okay, very good. What do we need to monitor in addition? This comes back to the vasculature of the brain. What do we need to monitor very, very closely?
Heart rate, their respirations, and their blood pressure all together.
And
Metal cells.
and
And
why end title? That's what I'm heading for. Why end title?
because I kind of knew that you wanted.
Okay. Why end title, folks?
Oh, because
Why is that important? You're right. So what happens to the vasculature of the brain if we blow off CO2?
Constricts.
And then what happens to the perfusion?
Sucks at that point.
foramen magnum.
And what happens to the swelling of the brain?
It's gonna go up.
It's going to go up. So we allow our end tidal to determine our rate and our depth. Cushing's triad is what?
Not good.
Increased ICP.
It is?
Yes.
Well, but what are the three
Widened pulse
parts?
pressure. Irregular respiratory.
And bradycardia. Okay. All right. Any questions? Do y'all need a break before we go into the exam?
5 minutes.
5 minutes. All right, take 5 minutes.